or the recording button. Just as a reminder, this session is being recorded and it will later be uploaded to our website. And we're conscious of protecting everybody's identities, so we'll not be posting anything to show attendees' names. So we've got everybody muted, cameras off, so that it's not captured on a recording. If you have questions, please put them into the chat, and either myself or Riley will answer those or read those out to Dr. Palazzo at the end. And sorry, I should back up a little bit. I am Jenny Knight. I am the Executive Director for the Grand Rapids LGBT Healthcare Consortium. And we're just very happy to be able to offer this education series. If you feel compelled to give, we do welcome donations to our Give Butter campaign, and Riley will drop that link in our chat. The donations would be given towards the trainings we offer throughout the community. Our MedPath Mentors group, which is a high school youth that are interested in healthcare, and we connect them with mentors, and then future events that we're planning on. Please feel no obligation, but if you would like to donate, visit our website and there'll be a donate button in the middle of the homepage. It will be dropped in the chat for you all. Also, our health experience survey is open for LGBT community members. We'd greatly appreciate your feedback on this with your experiences with healthcare. Our goal this year is to reach at least 150 respondents to provide significant data for surrounding healthcare facilities. We do share this with all of the healthcare systems in Grand Rapids. We're currently at 91 responses, and to create an impact, it's crucial to enrich the understanding of the experiences that our community face in healthcare settings. If you'd like to participate, please visit our website. Also, Riley is dropping that in the chat. And so with that, and also for anyone that is a social worker and a member of the NASW Michigan chapter, I do have that. I'm just dropping in the chat the link for you all to submit for the CEUs that they have attached to this. And if you have any other questions about that, please reach out to Danielle. So let's give a warm welcome to Dr. Chris Palazzo. Dr. Palazzo is a primary care physician at Corewell Health Campustowne Clinic. He's been part of the LGBT Healthcare Consortium since 2020 when he was doing his residency at Trinity Health St. Mary's Hospital. We're thrilled to kick off our new health education series with Dr. Palazzo, who will be talking about gender-affirming hormone therapy. Turn it over to you.
All right. Thank you so much for the introduction and everything you do for the community. All right, so we can see my screen, right, Jenny? So, we were saying, Christopher Palazzo from Corewell Health. I'm a family meds physician by training. I also have a focus on LGBTQ healthcare and improving patient outcomes for that community. I appreciate the opportunity to speak in this multidisciplinary group, because that's how we ultimately improve outcomes, is through everybody working as a team and having kind of knowledge base to be able to help this population. This is in no ways an exhaustive lecture on gender affirming care, but it is at least a starting point for further research if you desire. So we're going to do some review of language. I know a lot of folks in this group already are good with the language, know the language, so we'll do that briefly. We'll talk about why this care is essential, what is gender affirming care, what is gender dysphoria, what do appointments typically look like in the primary care setting, what non-hormonal care or support is available, and some common questions about gender diverse and trans youth. Just a disclaimer, I do not treat patients under the age of 18, so that is not my specialty. No financial disclosures. Just a start here with some language that's relevant to the talk. So knowing kind of the distinction between sex and gender. You know, sex is this classification based on person's hormones, chromosomes, primary and secondary sex characteristics, oftentimes assigned at birth. Gender is tied to a person's deeply held identity. We know that sex and gender don't always have to align. Some other terms, AFAB, assigned female at birth, refers to the sex assigned at birth, as well as AMAB refers to sex assigned at birth. Cisgender, we know sex and gender typically align. Transgender is kind of an umbrella term for a person whose gender identity or expression do not align necessarily with the sex assigned at birth. Transition is a big term and it means something different for everyone, so it's important to respect that, but trans patients may choose to transition their gender socially, clothing, name, pronouns, things of that nature, medically, hormones, and other medications, surgically, or in any combination or none of these combinations. So it's important to realize and recognize that not everybody wants the same thing, and transition doesn't mean the same thing for every patient. Would be remiss if I didn't bring up the gender unicorn or the genderbread person, but this is a good helpful tool with families, especially that are trying to understand gender identity, and how it's different from gender expression, and how sex assigned at birth is different from those as well. This also has some sexual orientation or attraction parts to it as well. So important care. So, we know with marginalized communities, there's bound to be social detriments of health, impacts health, and we have studied this for many years and know that this is true. Specifically in the transgender and gender nonconforming community, they face higher levels of poverty, violence, and discrimination compared to cisgender folks. There's a trans survey that has been done first in 2015, so most of the data is from this, but we do have preliminary data from Trans 2022 survey, which is very exciting because it was a robust response. 92,000 people responded, which is great, but we don't have all the data specifically, but I think it will be helpful once we get more. But the percentages are pretty staggering. 29% of people in the transgender community live in poverty compared to 14% general population. 30% of transgender people unhoused at some points in their lives, experience employment 3 times the rate of general population, and these numbers go up for transgender persons of color. 40% of respondents reported attempting suicide in their lifetime. So that's a huge number in a marginalized community, nearly 9 times the rate, the national rate in the United States. Some early insights into the 2022 survey. So some similar statistics, they've hashed out things a little bit more, but more than a third experienced poverty. Unemployment rate was at about 18%. More than 1 in 10 have been fired, forced to resign, or laid off due to their gender identity. Nearly 1/3 verbally harassed in the last 12 months. And that's 39% online. 3% were physically harassed in the last 12 months. So these are huge numbers. Specifically in healthcare settings, 1 in 9 of the survey participants reported being refused care to being transgender. 28% reported delaying their medical care when sick or injured due to fear of being discriminated against, and 28% also report being harassed in the medical setting. Early insights, nearly 24% in the 2022 survey did not see a doctor. So that's come down just a little bit. Of those who saw a doctor in the last 12 months, 48% report having at least one negative experience because they were transgender. So that's very concerning. And that's going to be hashed out more as far as what the negative experiences were. And this is a new thing that they've added, but approximately 26% have had at least one issue with their insurance company with medication or some other lab in the past year. So large percentage have insurance trouble. What is gender affirming care? Gender affirming care is integration, really. So that's why talks like this are so important, because it is an integration of medical, mental health, social services to support people with age appropriate care that is medically necessary. So we know this is medical necessary for the well-being of people in this community. So very important that we kind of all work together to provide gender affirming care. What does that look like in an office? Creating a safe and welcoming environment. I know Corewell at least has had a big push to make offices more inclusive. It starts at the front door. What are there signs or signals that this is a safe and affirming practice? Are there door stickers? Are there flags? Do people have badge buddies that indicate their pronouns or show some form of pride? And this should be kind of front to back. So clerical and client services staff to clinical staff should all be on the same page. You can't have a gender affirming clinic if, one person isn't on board. So there should be a good foundational knowledge there of gender affirming language and pronouns and trauma informed care. At Corewell, in order to be designated a safe and affirming practice, everybody in the office needs to complete gender affirming training modules. And you'll see those lanyards on the right of the screen at the front desk at all those clinics that have done so. Having gender neutral restrooms also can indicate a safe and affirming place. Affirming posters, art, books, and literature are also part of that. Having affirming registration forms. So a lot of registrations are done online, but if you have paper registration forms, make sure there's an option to mark these things: gender identity, sex assigned at birth, how you identify, your sexual orientation. These are super important because if there's not a space for these, people feel closed out right from the get-go before they even see you. And if there is a space for these, it's an option for conversation and discussion. So what is gender dysphoria? So many modern cultures, including the United States, gender is viewed through gender binary rather than spectrum. There are some cultures that do view gender more on a spectrum, but the vast majority are operating in a gender binary system. Gender dysphoria tends to be the distress or discomfort that occurs when gender identity and sex assigned at birth are not in congruence. Gender dysphoria can cause a whole host of symptoms and medical conditions: mental, physical distress, isolation, anger, self-hatred, as well as suicidal ideation. Going back to the trans survey, 40% of patients have reported attempting suicide in their lifetime. When does gender dysphoria develop? It's different for everybody, and everybody's journey is unique, which you will find. 2020 study in Journal of American Medical Association said 73% of trans women and 78% of trans men first experienced gender dysphoria before the age of 7. So a lot of people experience this at a very young age, even if they don't identify it as dysphoric feelings. Most studies suggest gender dysphoria develops in early life, but may not be recognized as dysphoria until later in life. And some folks find it hard to find language to recognize lived experiences causing dysphoria. What's important about this is, yes, dysphoria exists, but not every trans person experiences gender dysphoria, and it doesn't have to be a part of being trans. So many US insurance companies do require gender dysphoria in adult or adolescent diagnosis for reimbursement, which has led us to, using this a lot in the chart. And this has changed from gender identity disorder, which was the last ICD diagnosis. Transsexualism was before that. So the medical system has adapted to try to better become less offensive, but they're usually about 10 years behind in my experience. Journey with gender identity is unique to each individual. So just because one patient reports having dysphoric feelings doesn't mean everybody will have those same feelings. It's very important as healthcare providers to not perpetuate that certain stories are only valid or privilege some narratives. Some patients will have this false belief that they need to have a convincing story or they're not going to get hormones, and that's something that we want to negate right off the bat, so patients don't have this anxiety that that's necessary. A lot of patients think gender dysphoria kind of medicalizes the experience of being transgender, and this is a medical model that wasn't created by trans people and is forced to be put on trans people, so it's important to be sensitive to that. And like I said, gender is complex. Dysphoria can be a part of being trans for some people, but it's not the only thing that makes a person trans. It's important to have these conversations with people, especially if you're putting a diagnosis in the chart, being upfront and forward about, hey, I don't think that, dysphoria is a big part of your life, but this is something that for right now, insurance is requiring me to put this in the chart. As far as a diagnosis goes, lots of text on this slide, I'm sorry, but the DSM-5 classifies gender dysphoria as a disorder, and that's the dysphoria part that is the disorder. Gender variance is not a dysphoria or disorder or pathology. So many providers, especially in WPATH, the World Professional Association for Trans Health, are working on trying to get gender dysphoria out of the DSM and more into a classification of gender identity variance. Upcoming ICD-12, so we're on ICD-10 right now for billing, is set to categorize gender dysphoria as a variance of human experience and sexual concern, not a disorder, which is similar to how sexual orientation has changed over the years. And there's lots of discussions on how to preserve access to this care in limiting pathologizing and stigmatizing people. There we go. I'm not going to go through all these, but gender dysphoria in the DSM-5 is a marked incongruence between one's experienced and expressed gender and natal gender of at least 6 months in duration by at least 2 of the following bullet points. So you can look through those, but a marked incongruence between one's expressed and gender and primary and or secondary sex characteristics, strong desire for the primary and or secondary sex characteristics of other gender. As you can see, a lot of these are operating in a binary, but these are what goes into the diagnosis of gender dysphoria. Consent for gender-affirming hormones, at least in adults. So historically, a referral letter from a mental health professional was required prior to initiation of hormone therapy. It's not a requirement to start treatment. Many large volume and experienced transgender care providers have been using informed consent model for years. WPATH, World Professional Association of Transgender Health, version 8 of their recommendations shows that they have support for informed consent model. It's important to, patients ask if someone follows the informed consent model or requires a letter before initiating hormones. A lot of surgeons do still require letters from therapists before any surgery, so it's important to kind of hash this out. Specifically myself, I do not require a letter for initiating hormones, but that's not across the board. And to provide consent, 18 years and older, know that we document the risks, benefits, unknowns, and limitations to treatment. Some places a consent form is signed, so we tick all the boxes. This is kind of consent that goes into any medical care, really. What do appointments look like, at least for me? So, a new patient, kind of getting their story, getting their history, listening and gathering information. Important to start off, pronouns and gathering information about that, gathering information about gender identity and expression, and have they explored ways of expressing gender over the years? What has their journey been like with gender identity up until this point? So we can be on the same page with that. Again, this is when I say, I'm not looking for a specific story. Every story is valid. Some people find their gender identity at a very young age. Some people find it more in adolescence or puberty time. Others find it later in life, and all those stories are valid and deserve to be treated with validity. What kind of changes are we hoping to experience? What emotional changes are we hoping to experience? Those are kind of the things that we initially discuss. Very important to learn about social supports. Who knows about the gender identity? Do they have concerns with backlash from work or home? Are they in a stable living situation? Very, very important before starting any hormones. Pertinent medical history. So any history of uncontrolled or untreated mental health disorders. Mental health disorders are not a contraindication to gender-affirming hormones, but it is important, especially as a primary care physician, to make sure that these conditions are being addressed and adequately supported. Organ inventory, what organs do we have? Any personal or family history of clotting disorders, which is important with feminizing hormones. Any masculinizing hormones, looking for history of polycythemia. Any chronic medical conditions that could potentially be made worse. Taking a sexual history. Are you sexually active? Important to not forget about the ACE community and not thinking everybody is a specifically sexual being. Talking about PrEP, STI screening if patient desires is important time. Pertinent exam, not much needed on the first appointment. A lot of these patients have had trauma in the medical setting, so important to always ask, is there any part of a physical exam or physical touch that is traumatic to you or you would like me to limit? Because things even just like listening to heart and lungs over the chest can be sensitive for patients. So always asking before doing. Setting up a roadmap, what it looks like, typically have patients go do labs and then return for further discussion about hormones and what that looks like. So baseline labs, typically for feminizing, masculinizing hormones, typically getting similar labs for each. CMP, which looks at electrolytes, looks at kidney function, liver function. CBC looks at white blood cells, red blood cells, all those things. Testosterone levels at baseline, estrogen levels at baseline. For feminizing hormones, I like to look at a hormone called prolactin, which can elevate with estrogen. So important to monitor. All patients are offered STI screening. It's important to be aware of site-specific gonorrhea and chlamydia screening. That's includes rectal, oral, and urethral testing. Important to kind of get a good sexual history as well, so we know which sites are important to be screened, as well as syphilis and HIV, which are blood tests. Great time, especially in primary care. That's why I love gender-affirming hormones in primary care, because we're able to do screening tests that keep people healthy overall. Yes, being transgender is part of their health and part of their well-being, but there's a whole other part of their person that we're able to keep healthy. Talking about referrals, typically, in primary care, again, it's nice because we're able to deal with comorbidities like mental health, but if they need a referral to a therapist or a psychiatrist, we can discuss that. If there's a referral sometimes to hematology, if there's a history of blood clots or a history of abnormal blood cells, definitely important to talk about. Some patients like to talk about goals of surgery, but typically, initially, referrals aren't made right away. It's important to set, the expectations for what it looks like, doing lab testing frequently, following up visits, being kind of open communication to keep medications refilled, and then talking about medication options. So there's lots of different options, lots of different modalities, and consenting to medication. So what are our feminizing hormone options? So I've kind of simplified this a little bit, recognizing some folks aren't in clinical or pharmacology, but for estrogen, there's oral, topical, injectables. Really, there isn't one that's necessarily better than the other. A lot of times oral is started initially because it's easy to know how we're going to react to it. It's got a short half-life, meaning it's out of the body quickly. So if you do have a negative reaction, it's not lingering or sticking around. Sometimes this oral medication isn't absorbed well, so we do switch to different modalities. Similarly, there are other comorbidities that would make us lean more towards a topical, like a patch or an injectable, but that's typically kind of person specific. So estrogen is a big part. Androgen blockade, blocking testosterone, is also a part for some patients, typically with spironolactone. That's the most common and most well studied. Finasteride, dutasteride, or bicalutamide. Bicalutamide is used less frequently due to some concerns for liver function disorders, but it can be used if needed. And then progesterone is a lot of times a part of care, either in the prometrium or provera. I don't typically start this until 6 months to a year of being on estrogen. It can help with breast development. It can help with mood stabilization and things like that. Some people don't like it, and it's not necessary part for everyone. And none of these are all, doesn't have to be all or none. It can be different for every patient. There is some literature out there around progesterone causing increased risk of blood clots, increased risk of cardiovascular disease, increased risk of breast cancer. These are from a women's health initiative from the 70s that was based in cisgender women that were postmenopausal, so it doesn't necessarily extrapolate to our trans women population. And it was micronized progesterone and not kind of the um, bioidentical progesterone, so it's a little different form, but that research is out there if anyone asks. Goals of treatment, obviously to lower testosterone and provide therapeutic exogenous estrogen. Typically starting off, we do labs every 3 months until we're stable, and then can be spaced out every 6 months per provider discretion. Typically estrogen, testosterone, CMP, looking at potassium levels and LFTs if patient is on spironolactone, liver function test that is. And it doesn't have to be all these all the time once stability, but a lot of times at first we need to monitor closely what's going on in the body. Goal estrogen levels, typically between 100 and 200 total estrogen, and goal testosterone less than 55. It's never really a goal to get testosterone extremely low because that can have issues with libido. It's important to be open that, you know, everybody has different levels of testosterone and estrogen. It's never the goal to have your testosterone be at 0, but the goal is to decrease it less than 55. Some changes in timing of changes that are expected. You know, I always kind of give this as, you know, this is kind of sometimes a second puberty, and those changes take time. And sometimes it can be up to 5 years for changes to fully mature. The first things, you know, that you have to go over are what changes are permanent, because just because we're starting hormones now doesn't mean, you know, hormones need to be a part of your life forever. You can choose to come off of them at any time, but things are permanent and will be a permanent part of you, specifically breast growth, usually decreased sperm production, reduced fertility. So it's very important to have fertility talks with patients before starting hormones, changes in testicular volume and size as well. As you can see, the other changes there are reversible, usually, meaning if we stopped estrogen, those would revert. So masculinizing hormones, either injectable or topical, usually. Goals to provide therapeutic exogenous testosterone levels while decreasing estrogen levels. Dose and lab guidelines vary among institutions quite widely. Typical recommendations are similar, every 3 to 6 months for labs. It's very important to follow the hemoglobin and hematocrit because those levels can elevate, which are on a CBC test. There's a risk for polycythemia or thickening of the blood, which is important to monitor for. Our goal testosterone, typically between 200 to 1,000, and it depends on timing of injection administration or timing of topical administration. It's important with testosterone that higher levels don't necessarily mean more masculinization. There is a process called aromatization where the body takes excess testosterone and converts it into estrogen. So some patients with super therapeutic testosterone levels can get cramping, bleeding related to this process. So it's important to be mindful of that. It's important to know testosterone is not an effective method of birth control. So just because most people are anovulatory or not having menstrual cycles on testosterone doesn't mean that the possibility isn't there of pregnancy. And testosterone is teratogenic or lethal to developing fetus. So important to have these conversations, you know, what sexual activity looks like if sexually active. Are we coming into contact with sperm during sexual activity? To adequately counsel patients on potential need for contraception. Again, permanent reversible changes, so more permanent changes with testosterone, but body hair, facial hair growth is usually permanent. Deepened voice is is permanent, has to do with kind of the larynx and thickening of the vocal cords. Clitoral enlargement as well is a permanent change. Male pattern baldness is something that's permanent once it starts. Other things like movement of body fat and muscle distribution are you know, reversible. So what about for minors? So for consent, patients, guardians need to provide consent to care if patient is not 18 years older. Minors do need to be seen by a comprehensive team for evaluation prior to initiating gender-affirming medications here in West Michigan. For a diagnosis, there needs to be a history of persistence or the experience of the minor's gender identity over time. So this is a longitudinal documentation. Transition and affirming care does not always need to be medications, and that's important to recognize when you're dealing with all patients, including minors. So gender transition is a personal process, and the goals may be different for every person. Behavioral health support may be an important part of the patient's care team, especially if there's a lack of social or family support. There's a history of trauma, especially if they're a young person or minor. This is an important part of care. Before puberty, transition is entirely social, hairstyle, name change, clothing, and none of that is irreversible. And it's important in any sector of care that we're supporting this and encouraging this as a part of gender expression. Briefly, for gender affirming care for minors and hormones, there's puberty blockade. These are reversible blockades that kind of stop natal puberty. It's a pause button, and usually started at Tanner stage 2, which is early maturity, before Tanner stage 5, which is full maturity after puberty. And this can reduce anxiety and depression for a lot of adolescents. It's a very personal decision to add gender affirming hormones or when that's the right time. It's based on medical and social history, as well as other social factors. It's important to note that, people cannot be on puberty blockade forever because there is consequences on bone health and long-term health. So this is something that a decision for that addition of sex hormones needs to be made, but it's a personal process. It's ideal for these patients to be cared at a comprehensive clinic with support from medical care providers, therapists, support groups, social workers, but care should not be withdrawn or not accessed if this is not available. Some common myths and questions I hear, is it trendy for kids to transition? So being transgender or gender nonconforming is nothing new. This has been depicted as early as the Neolithic period and Bronze Age. This is something that has been around forever. It's just an increased awareness of being transgender, and stories are more widespread, so people feel safer coming out now. What if someone transitions and they change their mind? So, transition means something different to everybody. It's important to kind of define goals. Regret is pretty uncommon reported among transgender youth, especially. Some studies show that 98% of young patients continue their gender affirming care after puberty blockade into adulthood, and less than 1% express regret after gender affirming surgery in most cases. What do medical providers think about gender affirming care? Every major medical organization, including AMA, American Academy of Family Physicians, Obstetrics and Gynecology, American Academy of Endocrinology, basically every society has said that age-appropriate gender affirming care for transgender and non-binary people is important and essential to health. At Corewell Health, there is a way to have grievances or concerns or complaints brought to attention because people are still mistreated to this day. We saw earlier that 28% report being mistreated. So we have an integrity helpline, we have patient relations that you can email or call. You can always make specific complaints to medical board or LARA or Michigan Department of Civil Rights and the Joint Commission if there's concerns related to a specific experience with a provider. Some other resources here that are used frequently. So GLAD is another option for listing yourself as a safe and affirming provider. US Trans Survey, like I said, reports to be released soon for 2022. WPATH, or World Professional Association of Transgender Medicine, has conferences which are fantastic to attend, multidisciplinary. They release standards of care and they're on version 8 currently. TransLine is a very helpful website. TransCare at University of California, San Francisco has great guidelines and information. Here locally, LGBTQ Healthcare Consortium in Grand Rapids. Corewell has a LGBTQ patient navigator, Zoe O'Brien, who's fantastic as well at getting people to the places they need to go, which is a fantastic resource to have in the community. And that is all I have.
Awesome. Thank you, Chris. We do have a few questions that were put in the chat, and I do want to mention that The American Psychiatric Association yesterday released a statement that almost unanimous. I think they only had 3 or 4 people who disagreed with it, but they really put out a strong letter against all of the anti-LGBT rhetoric that's going around and trying to debunk some of the myths that were going around. So hopefully that has some impact to those
Awesome.
that listen to science and data.
Mhm.
All right, so Chris, one question was the 2015 survey that you mentioned. Do you know how many people were included in that survey?
That I don't know off the top of my head. I know that the 2022 survey is a huge increase from previously. So the word got out a lot better. It was distributed to a wider percentage of people. But I don't know the exact number of that.
Okay, thank you. And then is testosterone available in a form other than shots? And what are the negative side effects?
Yeah, so shots are very common. It's important to know that route of administration is important to discuss too, because testosterone doesn't have to be intramuscular. Most of the time I prescribe it subcutaneously because the needles are shorter, and it's less painful for patients. So that's important to talk about. But there are topical forms, gels. Patches were discontinued actually this year in the US. But there are topical gels that are an option. Sometimes insurance can be difficult with gels, but if you've tried injections, usually they're covered well. If there's some reason you can't take injections, like needle phobia, some people with ASD, have sensory issues, that can be a good thing for your doctor to add to the prescription, so it's covered by insurance easier.
All right. And Mark corrected me. It was the American Psychological Association. Thank you, Mark.
Okay.
And Riley found the 2015 transgender study, and it said there were 27,715 respondents across the United States.
So now up to 93,000 with this 2022. So
That's
a
a
lot
huge
better.
increase.
Yeah.
That's awesome. How would you respond if a client hasn't tried to express their gender identity in other ways? Is it a requirement to exhaust other options prior to receiving gender-affirming medical care?
So, a lot of things in this care, requirements are, really putting up barriers a lot of times for patients. And like I was kind of saying, is everybody's experience is different, everybody, just because someone's a transgender female doesn't mean they have to be super feminine or want to wear dresses or, want to wear their hair a certain way. We know there's a huge variation in gender identity. So I like to kind of see if there's been ways that they've expressed their gender throughout time. But if, I'm not pushing for someone to say, yes, I, wear makeup and wear dresses and this and that, because that's not the reality for everybody, even cisgender folks. So it's not an issue for me if someone hasn't, exhausted or, done other things. But it is an important part of someone's journey if they have, so it's important to know those things.
And that could be, well, that will be provider specific, what each provider
Right.
wants to see clients do. And another scenario could be that maybe the person just has always felt this way, but maybe they just are now in a safe place that they can explore this.
Yes, I've seen it a lot where it's been, especially 18, 19-year-olds who were in a very conservative household and just were never allowed to think that there was something other than being a boy or girl. And, so they're now realizing this, they've been around people and there's a light bulb moment. Oh my gosh, this is why I've been feeling this way. And, so it's not always, and some people in their 60s, 70s, could never come out to their spouse. And, for some reason, spouse is not in the equation anymore. And then they're kind of coming out at that age, and it's great, and it's, you know, part of the journey. So
All right. Most patients don't know, this person's experience is that most patients don't know how to evaluate surgeons. Do you counsel patients on how to assess gender-affirming surgeons' competency?
gender affirming surgeon's competency. So like knowing if a provider is competent in a procedure, is that?
Yeah, instead of the like fly-by-night care.
Gotcha. So most people, especially people that, you know, we refer to, are known specifically for doing procedures. You know, otherwise we wouldn't refer you or give you their name. Most of those people have robust reviews online too. So I think people that are going into this care are actively choosing to learn these skills and do this care. Um, there are fellowships and things of that nature now with plastic surgeons um, that specifically focus on this care. And, you know, we're really, a lot of those are in coastal cities. So we're really hoping and praying that people trickle to our beloved Grand Rapids area. But, you know, and there are surgeons that do focus on this in our town for specific reasons or specific procedures. But, it's important to have a conversation with your primary care doctor about, you know, do they know this person? Have they had patients that have had work done by this person? Because it can be a big deal, especially if you're going out of the state. So definitely, um, and I've called offices before to kind of gauge if that's someone who does this a lot or if it's something new or whatnot.
All right. What are birth control options available for those that are on testosterone?
Whichever option patient is comfortable with. So, you know, there's a big fear a lot of times with trans masculine patients that adding in a birth control is going to be estrogen or it's going to delay masculinization. Um, you know, so it's important to have a thorough discussion about what options there are out there and what's going to work best. Because you know, the only wrong option is the one that a patient doesn't feel comfortable with or is not going to use. So um, there isn't any that are contraindicated. Um, and, you know, just because we're taking a low dose estrogen pill, that doesn't mean that that's going to necessarily spike your estrogen levels significantly in your bloodstream, especially with the amount of testosterone that's around. So um, really having a conversation about, you know, what their fears with contraception are and helping them to make a decision, because there's always non-hormonal options too, like copper IUDs, but those are sometimes very dysphoric procedures, IUDs for patients, so not always at the forefront. A lot of my patients are on Depo or Nexplanon insertion though.
Awesome. Thanks, Chris. As we move towards depathologizing, I may have said that wrong, trans and gender nonconforming identities in DSM and ICD language, to what extent would adjustment disorder be an appropriate diagnosis for receiving gender affirming medical treatment?
Um, I don't know I haven't billed under that before, so I don't know personally. You know, there are certain games that need to be played with insurance in order to get things covered. Um, you know, so I can't necessarily speak to that diagnosis, but I know that ICD-12 is going to have new recommendations and hopefully more than ICD-10 for this realm of care because you know, it's becoming more and more of a mainstream part of medicine that people are talking about and discussing, which is great. Um, so I think we'll have our own set of diagnoses hopefully in the next.
Awesome.
And sometimes it's, you know, you have to kind of send it and find out with diagnoses. You know, if you send something and it gets rejected, then okay, we need to talk to insurance and see why and, you know, try something else.
All right. I'm curious about how an updated legal gender marker interacts with both insurance and medical records. Are there consistent issues with getting care and insurance coverage for things coded to gender marker?
So yes, initially that can cause some frustrations, especially with insurance. The medical system, it's a pretty seamless process. We change as soon as we see documents, but with insurance, they can lag behind. So it's before doing those things, it's really important to have, someone at the insurance team that is aware that this is happening so they can look out for it and not to, you know, change care or what's covered based on that. Because we can see a lot of kind of coverages changes if someone's not looking in the chart deeply and they just deny something because of a gender marker, which there's not a great way around it at this time. Most patients, it's kind of a few month lag and then things settle themselves out, but insurance is always a little bit behind. I'm sure most of you've realized. So it's important, on our end, we talk with, Priority Health and Blue Cross a lot to try to straighten things out for patients too.
All right. What percentage of your patients are late transitioners, older than 40?
I don't have an exact number. And, as far as starting over 40, I would say it's hard to say, but it's pretty common, especially in this area, that we see some later transitions. Probably, 15% or so of my patients, if I had to guess.
Is approval or sign off from a mental health professional still required for gender affirming surgery?
Surgeon dependent, but most surgeons here in town definitely require a letter of support from a therapist. And that's outside of some people requiring a letter of support from hormone prescriber, but most surgeons do require that still.
And I can say I'm former practice manager for the surgical breast clinic that does the TAP surgery clinic, and that requirement was from the insurance companies.
Mm-hmm.
They required we had a letter of support from the mental health therapist, and a couple of the insurance companies required a second letter of support from a PhD or higher level behavioral health professional. So most of the time it was reassurance requirement that the surgeon then has to meet to get the prior authorization approved. Just an FYI. Is there a benefit to taking estrogen before getting TAP surgery?
Estrogen before top surgery. Not that I've learned of, as far as how that would be beneficial, with uh, some revitalization of uh, breast tissue, might be part of being on estrogen, but I haven't heard of that being studied or looked at as beneficial to surgical outcomes, at least.
All right. Carrie, who is a social worker at the Gender Care Clinic at Helen DeVos, says, "Are surgery insurance?" Oh, sorry, Carrie. I thought you were answering the question. Are insurance companies still requiring letters for hormone therapy?
Insurance companies are not requiring because that's kind of what I've done for more than 3 years now, and I haven't needed a letter for
I
insurance
just need the diagnosis, correct?
diagnosis. Yep.
Okay. And then someone else put in, most surgeons will not augment if have not been on hormones for at least 1 year in this person's experience. Well, that's good to know.
Yeah. So a lot of times with either testosterone or estrogen, that can be a part of outcomes of the procedure. So they do like to have at least been on hormones for some time. There are certain procedures that don't require hormones to be a part of the surgery, but a lot of them do improve outcomes.
All right. And someone asked if there are other PCPs in the area who will see patients for hormone therapy. And there are. I know there's several. We have several on our website, on our provider directory that will start and continue primary care or hormone therapy.
Yes, there's lots. A big push for Corewell. I give a lecture twice a month on a little more in-depth medical than this lecture, but that is the goal of getting primary care people all over the state of Michigan, comfortable with prescribing this, so people aren't having to travel 50, 60, 70 miles for this care, which, primary care providers provide these hormones for cisgender people every day, so there's no reason they shouldn't be able to provide them for trans folks.
Can you talk about the benefits of becoming WPATH certified? Is it necessary to providing letters of support?
So WPATH certified, WPATH is a great community. There's a wealth of knowledge. I was recently at their conference in Denver, and it's really a fantastic experience. So I feel if you're interested in this care and are part of the healthcare system, definitely take advantage of that. Becoming certified isn't 100% necessary. Being up to date with the guidelines and reading the guidelines through WPATH and knowing them, it's a long document, but that's essential to providing this care, is important. But I think that just adds, to it displays kind of a expressed interest in this field and a desire to be most informed and staying up with WPATH recommendations. So I do encourage it for people because it's a great society.
And I know when I was running offices, we looked at it that it's quite in depth to do that WPATH, even just to read the guidelines. So we looked at it that if somebody was willing, they had to do this on their own time, and if they were willing to invest that time, they were invested in this care.
Exactly.
How would birth control meds mix with testosterone for a trans male? Specifically asking how birth control meds might mix with testosterone for a trans male.
Yeah, so everybody has testosterone, everybody has estrogen in their body. It's just the ratio that kind of society links to masculine or feminine. So, everybody has these hormones, and the idea with testosterone is we're giving a therapeutic dose of testosterone to suppress a lot of our estrogen production. So adding in a progesterone only or a combination estrogen progesterone contraceptive, yes, does have hormone as a part of it, but the idea of having a cis male level of testosterone is that it suppresses any feminization related to it. A lot of times this, needs to be proved to patients with, more frequent lab testing to say, look, your estrogen level is not increasing and you're on a contraceptive pill. But it's sometimes very hard, and it's important to be sensitive to that the idea of putting estrogen or progesterone in their body is dysphoric to them. So, coming up with an option that works for them is the most important part of this. And kind of showing them the confidence that this isn't going to lead to feminization. This is only a part of contraception. And there's always the conversation that can come, if someone is adamant and they, don't want their uterus anymore, discussing a gender-affirming hysterectomy, that can be a part of care as well.
Awesome. All right, one last question. Oops, I just lost it. One last question, and then we're going to have to end. Does hormone therapy impact the effectiveness of hormone-related birth control?
It's hormone therapy, not to my knowledge. Basically testosterone is thought to lead to anovulation, so we're not ovulating, but there is the theoretical risk that we can still ovulate with low estrogen levels. So there really isn't an interaction with level of effectiveness. We look at patients with conditions like PCOS, where testosterone levels can be higher in cis females, and that doesn't necessarily negate the effect of contraception.
So, thank you, Dr. Palazzo, for your time. We appreciate how your office is working towards being a safe and affirming place for the community. Thank you very much.
Yeah.
And again, I'd like to remind everyone about our Give Butter campaign. And please feel no obligation, but if you would like to, we will put that in the chat. And Riley is also going to send you all an email afterwards with all of the links. And then as we get this uploaded onto our website, it will be available. That may take us a little bit. So also about our health experiences survey. And I know people are very survey fatigued and get really frustrated with getting surveys, but this really does help guide the work that the health systems are doing. And they really do need to hear from the community themselves how their work is impacting the community for good or bad. And then next month, our session is from Duncan Lake Speech Therapy, and they're going to be doing a session on gender-affirming voice therapy. We will have the registration and the marketing materials up for that very soon so that people can get registered. So thank you everybody for joining us and for making our first session in the health education series go so well. Thanks, Dr. Palazzo. I so appreciate all your time.
Thank you all. Have a good rest of the day.
Have a good day, everybody.